Hello, I'm Dr. Bridget Nash, and I'd like to welcome you to The Therapy Show, a podcast series that seeks to demystify mental health treatment. Today, I'm honored to welcome Dr. Vibh Forsythe Cox, who is a consultant and trainer for behavioral tech, the training company founded by the developer of Dialectical behavior therapy, Dr. Marsha Linehan. Dr. Forsythe Cox is a licensed clinical psychologist in Washington State and a DBT Linehan board-certified clinician. She is the training and content development specialist at Behavioral Tech and was a primary content developer for Behavioral Tech's comprehensive online training, which is an online continuing education resource for therapists interested in being trained in dialectical behavioral therapy. Dr. Forsythe Cox is here to discuss the topic of dialectical behavior therapy, which is more commonly referred to as DBT. Dr. Forsythe Cox, welcome to The Therapy Show.
Thank you. Thank you for having me. I'm excited to talk about this topic with you.
Can you start by telling us a little bit about your personal background and professional development that informed your interest in DBT?
Sure. When I entered graduate school, I was very interested in personality disorders, and I worked with Dr. Jennifer Chevins at The Ohio State University. And when she learned about my interest in borderline personality disorder, she introduced me to dialectical behavior therapy, and she was also the first person to train me in the treatment. And so as I developed my skills in practicing this therapy and practicing in a lot of different types of settings with different types of clients, I began to get a stronger understanding of the treatment and experiences that I could share with others to help them improve their practice of the therapy and help them figure out how to best apply the treatment in their own settings. So I ended up supervising trainees for Dr. Linehan's DBT practicum at the University of Washington. And my work teaching and supervising those trainees, my background with various DBT settings, made me a good candidate to become a trainer and consultant with Behavior Tech. So Behavioral Tech is the training company founded by Dr. Linehan, and my passion for the treatment and helping others learn it is what led to my work with them.
How would you briefly explain DBT to a non-professional?
Dialectical behavior therapy was first developed for use with clients who are suicidal and self-harming. What Dr. Linehan brought to the treatment scene at the time was really unique was that instead of conceptualizing suicide and self-harm as the problem to be solved, she conceptualized them as efforts to solve a problem. She found that people with high, intense emotions often did behaviors that led to circumstances in life that just kept them in this cycle of pain and suffering. And when their lives were such intense suffering, they didn't want to live those lives anymore. And the only way they could see to solve that problem was to end the life. And so Dr. Linehan decided that actually, if we could help people change their lives to a life that they experienced as worth living, they would stop trying to end that life. And so it really led her to a place of thinking about accepting where people are in the moment and how to push them for change. And so this is also the connection to the dialectical. So dialectics are a concept from philosophy, basically that two ideas that seem to be opposed or seem to be in tension can both be held as true at the same time. For example, I am a child and I'm also not a child. So how do you think? How can both of those be equally true at the exact same moment? What are your thoughts?
Well, I'm an adult, but I also have a childlike spirit.
So that's one idea. And in dialectics, we're really thinking about how can we find the kernel of truth in both? And so for me, I have parents and my parents are still living. And so as long as I'm alive, I will always be their child. So I am a child in that I am their child. I'm also an adult. I'm over 18. I'm not considered a minor. In that way, I'm not a child. And so both of those things are equally true at the exact same moment. And so when we look for those ideas of how things can be true at the same time, that's called searching for the synthesis. And so this is something that shows up a lot during the treatment, what I was talking about earlier in terms of acceptance and change. You can understand how somebody got to where they are and at the same time really push hard for them to change. And it's that balance, that's one of the core dialectics of DBT. That's really the primary dialectic of the treatment, is that balance between acceptance and change. DBT works to help people let go of extremes. And so not only are we understanding the client in terms of dialectics, but we're also helping them understand that concept so that they can let go of extremes in their thinking and increase their behavioral flexibility. Because sometimes people will get caught up in extremes thinking like, if this person loved me, then they wouldn't do this thing that hurts me. And those ideas seem to be in tension. But when you bring in a dialectical philosophy or dialectical worldview, you can actually gain some more flexibility by asking the question, how could somebody really love me, really care about me, and still do this thing that hurts me? And so it could be that they think they're acting in your best interest. It could be that they don't know how much it hurts you. Then you start actually looking for what are the ways that both of these things could be true at the same time. And so that's how dialectics, the concepts of dialectics, help both the therapist and the client. The behavior reflects the fact that we focus on particular behaviors and what prompts those behaviors. It's often emotion. And what we need to do to help our clients make the changes they need in order to get closer to their goals. And so we do that by understanding principles of behavior like reinforcement and punishment, but also by teaching the clients skills. DBT is a skills deficits model. And so that idea is that people, for whatever reason, may not have had the opportunity to learn or practice the skills they need to build a life that they experience is worth living. So we actually intentionally teach clients skills. But DBT is delivered in 4 main modes, and that's individual therapy. Then they get the group skills training. There's also between session consultation to help those skills show up in the places where they really need them. And then consultation team to kind of help the therapist stay balanced, because not only are clients impacted by emotion, but so are therapists. And sometimes when you're working with people who are at high risk of dying by suicide or who are doing behaviors that are maybe harmful to themselves and others, emotions come in. You can have a lot of fear, you can have a lot of frustration, and the consultation team is there to help the therapist regulate their emotions and keep their eyes on their goals. So that's a little bit about DBT and how it's organized.
I like that it supports both the client and the therapist. That's very good.
As a DBT therapist, I like it too. And I think that it really helps you keep a strong enough relationship with your client and keep their goals in mind in a way that really helps everybody in the treatment.
Why are skills so important?
So that goes back to the skills deficit model part of it. And so given that premise that people may not have all of the skills they need, then it becomes really important to teach them those skills. So DBT skills training includes mindfulness skills. Those are considered the core skills of DBT. They're really skills for helping you organize your attention and put your attention on the thing you need your attention on in the moment. Include being able to observe your sensations, the situation you're in, to be able to put words on the experience, to be able to throw yourself in and let go of thoughts that might be pulling you out of the moment. Those are just a few of the mindfulness skills, and that ties into how you use the other skills. So by being able to observe and describe, let's say, what's going on, you get more information so that you can choose whether or not you're in a crisis situation and you need distress tolerance skills, or whether the problem is emotion and you need to figure out how to regulate your emotions, or whether there's something that needs to be communicated and you need interpersonal effectiveness skills. So the mindfulness skills keep showing up in terms of their own benefits for helping us slow down and regulate our attention, but also in how we use the other skills. So then the other modules, let's start, for instance, with distress tolerance. These skills are for what we call crisis survival. Sometimes there are situations that involve high emotions, can't necessarily solve the problem immediately. You just need to be able to get through that moment without making the situation any worse. So something I tell my clients is, and I forget where I heard this now, but something I tell my clients is the first rule of holes is, if you are in a hole, stop digging. And the crisis survival skills are really for that, is to sometimes when people get overwhelmed, they make impulsive decisions. They make decisions that are about getting relief in the moment. And then later they think like, oh, if I hadn't done that, I'd actually be in a better place. And so the distress tolerance skills are for helping slow down and not do anything that makes the crisis worse. And that applies all the way from self-harming or drinking to even calling someone and shouting at them when that's something that would make the situation worse. They can be applied all across the spectrum. It doesn't have to be dangerous to be a moment that needs crisis survival. And so once you kind of get through the crisis situation, if there is one, then sometimes you need longer term emotion regulation. Sometimes that involves figuring out how to problem solve the situation. Maybe your emotions are up because of what is happening around you, and you need to figure out how to reduce the threat. For example, if I get a notice that one of my bills is late, and then I have a lot of fear and anxiety build up, and I think, what am I going to do? I need to fix this. My lights are going to get shut off, those kinds of things. That situation might actually need problem solving. I might need to figure out how to pay that bill. Or it could be a situation where I am meeting up with a friend that I haven't seen in a really long time, and I feel anxious. I feel worried. What are we going to say? Is it going to be boring? Are they still going to like me? And what I actually need is not to find a way to get out of meeting up with them. I might actually need to figure out, how can I tolerate this anxiety or bring this anxiety down enough that I can really go and enjoy this time with my friend. So emotion regulation skills help us do that, either solve the problem or figure out how to decrease or sometimes increase the intensity of an emotion. Those are the skills for communicating your needs and taking care of your relationships and your self-respect. So they include skills for how to make an effective request to increase the likelihood that your needs will get met, and how to communicate in a way that keeps other people wanting to communicate with you. And so a lot of people think about those skills and they think, oh, well, I don't really want a relationship with everyone. And what I usually say is that it's important to think about keeping the other person wanting to communicate with you, even if you're on a customer service call. Because if you have that call and you make your request in a way that makes the person on the other end of the line really frustrated and not want to talk to you, the likelihood that they will work as hard to get your internet connected or whatever it is goes down. And that actually taking care of that relationship, even though it might be a short interaction, increases the likelihood that you'll get your needs met. And then there are ways to get your needs met that your self-respect might take a hit. And sometimes you have to prioritize in the situation, whether your main objective is the important part, getting your goal, whether taking care of the relationship is the important part, or whether your self-respect is the important part. Because depending on which one is your primary goal in the situation, you might do different behaviors. For example, if I need to get a problem solved, the grocery store is out of something that I really needed. Let's say it's out of hand soap, which is something that's happening right now. I could lie on the floor kicking and screaming until somebody found some hand soap somewhere to give me. Or I could ask, and if they said no to that ask, I could choose that, okay, I'm going to accept this no gracefully because this is what would help keep me self-respecting. I don't know if that example really helps illustrate it, but it's really about making sure that you get your needs met in ways that help keep you liking yourself in the way you approach life. Because if you don't think about that, sometimes you get your needs met, but it really wears away at your self-esteem. I think the skills deficit model, I really like it because it feels really compassionate to me, because it's not assuming that people are self-sabotaging and they want to be in suffering and they're doing all of these things on purpose to hurt people around them. If I can think of it as sometimes people lack the skills. They don't know exactly how to make a request. This is the best way they know to get their needs met. This is what they've practiced. This is what has worked. If we can teach people new ways of solving problems, there's no reason to think that they won't use those new ways that might help them and other people feel better. And this is actually how the targets of the treatment are organized. I guess I'll connect the skills to the targets of the treatment, but basically, if you think about your life worth living, that's the first thing I ask clients to do is, what are the things that you would really want to have in your life that would help you experience your life as worth living? And then we figure out what's been in the way. So for example, if someone says, I really want to have just a few meaningful relationships. And then I ask, okay, what's been in the way? And they say, well, I don't know how to approach people. I see someone, they look interesting, they look friendly, but I just can't make myself walk up and say hello. Then we actually can target, okay, initiating interactions might be one of your targets of treatment. And we can actually teach you the skills, whether it's to bring your anxiety down in that moment so that you can go up and talk to the person, whether it's that you want to figure out what you're actually asking of them and figure out what to say, or a combination of those things. We can figure out which skills would help you be able to approach more people so that you could build those meaningful relationships in your life. Alternatively, someone could have that same goal. I want to have a few meaningful relationships. My problem is I can approach people just fine and talk to people and make friends and they like me. But if they do something I don't like, I get so angry that I end up saying really hurtful things and it ends the friendship. And so that might be the place where we go, okay, so what you might need to target is how to not say hurtful things when you're upset. And that might be some emotion regulation skills. It might be some interpersonal effectiveness skills, how to communicate what you're angry about in a way that you actually get heard and the conversation moves forward. So we can actually identify the targets that they want, the things that people want in their lives, and what are the skills that they need or need to practice that would help them get there. And then, as any good teacher or coach will tell you, it's not enough to be told about a skill. In order to get good at a new skill, you have to practice. So DBT also involves a lot of the individual therapist, the skills group leader, helping our clients figure out how and when to practice their skills.
Many of these maladaptive, we call them maladaptive behaviors, are due to an invalidating environment. So because of this environment, maybe these skills were not taught, or maybe a person didn't really know how they felt about certain things because many times their feelings were invalidated by the environment. It's just that this person didn't learn these positive skills, these adaptive skills, and we can learn them at any time in life, right?
That goes back to how DBT was developed. So the treatment is based on what we call the biosocial model. And so that is the idea. Two main concepts, just like it sounds, the biology and the social part. And in the biology part, it's that people are different. You hear that all the time. But this is a specific idea about how people are different when it comes to emotional experiencing. Some people may just be more sensitive to emotion in that more things can set an emotion off for them. For me, I would put myself on the sensitive end of the spectrum. How sometimes you're walking down the street and maybe you guys see a dog and one person goes like, oh, a dog. And the other person goes, oh, a dog, so sweet. Where's his family? They both have the same cue, the same prompt, but they have different emotional responses to that. For one person, seeing the dog set off may be an emotion, and for the other person, maybe not really. Then there are differences in emotional intensity. So how strongly we feel an emotion when it gets set off. So if you are at work, let's say, and your boss comes by and says, all right, everybody is going to have to work overtime. Everybody's going to have to stay an extra 2 hours. I imagine everybody in that workplace would be feeling an emotion. My emotion would probably be frustration. And whereas one person might go under their breath, oh, this job is so frustrating. Another person might go, what? You can't treat us like this. I'm leaving. We're on strike. And they knock all the stuff off of their desk and walk out. Those two people had the same prompt. They maybe felt the same emotion, but it was at different intensities. And so that's another way that people can be different in emotional experiencing. And then there's also slow return to baseline. So that's the idea that when an emotion gets kicked off, sometimes for some people, it can come down pretty quickly. And for other people, it just takes them longer to get down to their emotional baseline. And then if you're somebody who has that slower return to emotional baseline, that's just more time when you're not yet feeling yourself, when other things can happen that prompt emotion and spike it up higher. So that's the biology part. And then what you were describing is related to the social part of the model. And so those things really have to do with having an invalidating environment, as you mentioned, which can be difficult transaction if you're also somebody with emotional sensitivity or emotional intensity. Because what happens is you end up having a lot of experiences that other people don't have. And then your environment might just respond to that in a way that tells you that your emotions don't make sense. They might say, why are you making such a big deal about this? Or this is not something to cry about. Or I'll give you something to cry about. And they might actually communicate that your emotional experience just doesn't make sense and you shouldn't be having it, rather than helping you figure out, okay, here's how you regulate that emotion in this situation. So you end up losing out on opportunities to learn how to regulate emotions. And you also end up questioning yourself. Like, should I really feel this way? Maybe I won't say anything. Maybe I won't do anything because I know I'm weird and I shouldn't be feeling this way. So those are some of the impacts that an invalidating environment can have. And then there's also inconsistent reinforcement, which is the environment maybe will say to do one thing, but actually you get your needs met for doing another. So for example, the kid who asks, Mom, I'm really bored. Can we please leave? And mom says, just sit, play quietly. We'll leave in a minute. Mom, I'm really bored. Can I please leave? Okay, just sit and be quiet. Give me another 2 minutes. So the kid waits 20 minutes, another hour goes by. Mom! And then they start kicking and screaming and crying. And the mom says, oh, I'm sorry, we have to go. So that kid got told, sit and be quiet and your needs will be met. But sitting and being quiet did not get the needs met. What actually got the needs met was kicking and screaming. And so your environment is telling you one thing, but reinforcing another, which just makes it really confusing to figure out how to do what will get your needs met.
I love that story. Can you explain the concept of wise mind?
It can be kind of hard to put into words. It's one of those things that you can't really think your way into. The premise is that everybody has inherent wisdom. And sometimes clients who've had really difficult lives and done a lot of behaviors that they regret, feel like they've made a lot of mistakes, will say, nope, that's not me. I'm the opposite of wise. I don't have any wisdom. I have no idea what to do ever. But the idea is that even though we might act unwise sometimes, it might be because we don't recognize, or we recognize and choose to ignore, our wisdom when it shows up. What we're doing when we practice the wise mind skill is actually helping people learn how to be open to that wisdom coming in and how to recognize their wisdom when it shows up. So you often see a Venn diagram with reason on one side and emotion on the other, and wise mind being the place where the two overlap. Reason mind is the part that considers cold, hard facts, logic, rational planning, what are the consequences going to be? That's that side of our brain. Emotion mind is the part where we have our love and fear and anger and also all of our values. So both parts are actually important to a wise decision, and being in either extreme can be bad. So if you're thinking about something like if you're trying to buy a house or choose a partner or decide whether or not to get a puppy, you need the logical, reasonable planning part of your brain. You also need to be able to recognize your values and the emotions that come up, because that's how you're going to find what the moment calls for and make the decision that is best for you. So wise mind is that experience of holding both reason and emotion at the same time and figuring out and doing what the moment calls for. And so that's another dialectic, being able to hold reason and emotion equally at the same time. Wise mind can look like the reason mind part, or it can look like the emotion mind part. So just like a child can look like one parent, or look like the other parent, or look like a combination of both, that's how it can be with wise mind. You can't always tell by looking whether or not you've considered both sides, but that's why you kind of do the practice beforehand of being open to both.
It often occurred to me that since DBT skills are such important life skills, why don't we teach it in every middle school? Can you share any research being done with middle school students?
Actually, I think the best place to get information on DBT in middle school, there is research out there. There is a program called DBT Steps A that has been developed and researched by Dr. James Mazza and Dr. Elizabeth Dexter-Mata. And that's really the program for teaching DBT skills, even to a non-clinical population in middle schools. As far as teaching people skills as they're learning, as they grow up, there's also DBTC, which is a protocol developed by Dr. Francesca Paraplechkova for children and pre-adolescents who are 7 to 12 years old. So I think that looking at their work might be the best place to get information about DBT with those populations.
What's the average length of treatment for somebody working with the DBT model?
I would say that the average length of treatment really depends on their targets of treatment. In the original study's standard DBT, the clients were in treatment for 1 year. They did 6 months of group skills training, which is where they learned the skills that we discussed previously. At that time, some clients might feel like they have met their treatment goals after they graduate skills training. And so they can have a conversation with their therapist, evaluate their progress on their treatment targets, and decide whether or not to continue treatment. Similarly, other people might feel that even at the end of treatment, they still have clear targets, they're still working effectively with their therapist to move toward those targets, and they can talk with their therapist about extending their course of treatment. I think the important thing is that for the length of treatment to be based on your targets and your progress toward those targets, and actually having discussions with your therapist about that. Most therapists are really open and flexible and willing to think about what you're raising in terms of whether or not to end treatment or continue treatment for longer. But I think that that's the best way to determine the length of treatment.
Who is DBT most effective for, and why should people choose a DBT intervention?
Dialectical behavior therapy was initially researched as an intervention for people with problems associated with borderline personality disorder. It is also a behavior therapy, and so it really focuses on the behaviors. So someone doesn't have to have borderline personality diagnosis to benefit from DBT. It's really a question of whether the problems that they are facing in their lives are a result of emotion dysregulation. And so lots of different populations struggling with severe emotion dysregulation and the behaviors that are associated with that have found benefit from this particular treatment. So if we look at the DBT research, there have been over 21 randomized controlled trials on comprehensive DBT, and think about 15 trials of skills. And it's consistently shown DBT to be effective for adults with borderline personality disorder, adults with BPD and a recent suicide attempt or self-harm, and then also BPD with comorbid problems like substance abuse, eating disorder, post-traumatic stress disorder. There are some studies of DBT being effective with older adults with personality disorder and major depressive disorder, and then also with children with severe emotional and behavioral disorders. As to the question of who it might be a best fit for, I think that decision is best made between a client and their provider. Some providers, even if they are not themselves a DBT provider, through a discussion about clients' particular problems that they're facing, the behaviors that they have, that therapist might be able to say, I think a good treatment for you would be DBT. That might be something to try. So you don't have to worry that you need to initially find a DBT therapist and they can decide. But really, a conversation with a treatment professional who is familiar with DBT and can have that discussion with you would be the best way to figure out if that could be a good treatment for you.
Can you explain the traditional DBT model and how it is often modified for use at different levels of care? And can you also talk about the importance of being trained in this model? It's not something that you would do without proper training. Is that correct?
Yes, I would say that's correct. And I find that people usually seek training in DBT because they have populations who are at high risk and high need, and they want to give them the best possible treatment. And so it actually helps therapists feel more competent and reduce their fear if they can be trained in a treatment that is effective for people who might be suicidal or self-harming or have substance abuse behaviors that actually put them at high risk of death. I think that for that reason, many therapists don't want to engage in this treatment unless they have been trained, because it's typically used with such a high-risk population.
But it can be modified, is that correct? Let's say a therapist like me who's not trained through Marsha Linehan's DBT Center wants to use the skills to teach their clients. Could that be used in a less traditional way?
I will say that two ends of the spectrum when I think about different levels of care. DBT was developed in a standard outpatient treatment model. And so when I think of higher levels of care, I typically think about hospitals and residential settings. I guess not really lower levels of care, but possibly implementation with people who are not having high risk behaviors. That's sort of the continuum that I'm thinking about. And I think for me, making that decision is about making sure that if somebody has the behaviors which DBT was specifically developed for, to make sure that they get that comprehensive treatment. Because we have data, we have information that it helps for people who are suicidal or self-harming. We have data that all of these pieces together help them. We have less data about what happens if we just give them some of the pieces. So if you're identifying somebody who is a good fit for DBT in that they have these problem behaviors, then that might be a person who needs comprehensive treatment. And if somebody needs comprehensive treatment, I would say in that case, you wouldn't want to be splitting it apart and doing something different. But if you have somebody who's maybe not doing high risk behaviors and you're thinking, just the way you said earlier, that it's possible that everybody could benefit from these skills, and teaching them those skills to enhance a treatment that they are already doing, that they already have, I could see potential benefits for that. I think that making sure that people have the right treatment for the problem that they are coming in for is important. And if there is one evidence-based treatment for that, I would recommend trying that first. And then if you find that something is missing, then thinking about, okay, what is the piece that's missing and what's the best way to find that piece and get them that support that they need. In terms of adaptations for higher levels of care, I think the way that we typically think through that is that comprehensive treatment is meant to serve 5 main functions. That is increasing the motivation of the client, enhancing the client's capabilities, helping the client generalize the skills they've learned to their environment, structuring their environment, and increasing the therapist's motivation and skill. And so that's where the 4 modes of treatment of standard DBT come from: the individual therapy, the group skills training, the between session coaching, and the consultation team. Those 4 modes of treatment are meant to be the ways that those 5 functions get met. And so then when you're looking at another setting, the main question is, what are the functions of treatment and how can we get those functions to happen in this setting? So even if they might have limited capability in terms of providing individual therapy or limited capability in terms of providing skills training, figuring out how do we get this function of enhancing the client's motivation and enhancing the client's capabilities, and what can that look like here where we are? I can recommend, in terms of figuring those things out, there is some evidence about the benefit of skills training alone. Even though in many of those studies, it wasn't alone. People still had case managers who could assess suicide risk and things like that. But there is evidence for the skills training component in that way. And so in the skills training manual, there are different curriculums and resources for people to use in different settings. Also, if you're interested in more of the variety of adaptations, there is a book called Dialectical Behavior Therapy in Clinical Practice. That's by Dr. Linda DeMeff and Dr. Kelly Kerner. And then there's also more recently published the Oxford Handbook of Dialectical Behavior Therapy, and that's by Dr. Michaela Swales. And both of those books are composed of contributions by a variety of experts in DBT, writing about their research and experience in implementing DBT across different settings and with different client populations. So those could be some places to learn some more too.
Thank you. That's very helpful. What skills, habits, or tactics can clients adopt either during their sessions or in between sessions to improve the effectiveness of DBT?
Practice, practice, practice. One of the core concepts of DBT is that more skills might be needed to get closer to our goals. And the best way to get skills under our belt so that we can use them flexibly and exactly where we need them is to practice those skills in a variety of contexts. So it's not enough if you and I are in the therapy room together and I tell you, okay, here's what you need to do. And I make a plan and we practice it. We do the role play, demonstrate it. You've got it down in the therapy office. That actually might not be enough to get that skill to show up when you're having a fight with a family member or when you are at work and you get really anxious or frustrated. You actually have to find a way to get the client practicing the skills outside of the therapy office and in the contexts where they need it. And so really openness and willingness to practice anytime, anywhere, and at the drop of a hat, in session, out of session, I would say that that is one of the biggest things you can do to improve the effectiveness of DBT. And I think that advice goes for not just clients, but also therapists. The therapists need to practice the skills they need to be the best therapists they can be. And that can include practicing in their consultation team, practicing outside of team, using the skills when they are out in the world. at least my experience has been that once I learned the DBT skills, they started showing up more and more in my life, in my conversations with my husband, in my conversations with friends, if I have a customer service number I need to call, when I dropped my keys down an elevator shaft, which my skills group loved that story about how I dropped my keys in the elevator shaft and I was able to name at least 7 skills that I needed to use in that situation. You start seeing the skills show up in the world, and there are lots of opportunities to practice. And then I think also practicing the skills and strategies you use as a therapist, like a behavioral chain analysis, for example, is one way that we kind of figure out what's leading up to target behavior, whether it's a behavior you want to increase or decrease. One of the things we do is kind of ask, okay, where's the first time that the idea to do this behavior popped into your head? What kind of happened between then and when you did it, getting as much detail as possible so that we can figure out where is the place that we could make a change. And I think that that's also a skill that it's good to practice as a therapist outside of the session, practicing with yourself, practicing with others, just how to get good assessment, asking detailed questions.
I love the behavior chain analysis. And I loved how somebody once in a video I was watching compared it to when you go in to see the doctor and you have, let's say you have a cold, you give them a list of your symptoms and the doctor sort of helps you figure out, well, when did you start feeling that way? When did you start to have that symptom? And then the doctor's kind of asking you to sort of do a behavioral chain analysis right there in the room. I just think it's a powerful tool.
Oh, I'm so glad you like it. I think a lot of people are shy about doing a behavior chain analysis. And if you can take out some of because sometimes people worry that they'll feel embarrassed or feel judged. But if it can really just be a conversation about what are the steps, what are the things that happen, it can be a really great source of information. And sometimes it can be really validating, really reassuring, help bring down unjustified shame to actually see, oh, it makes sense then how this thing happened. Right now that I've laid out all the things that went before it, it makes sense that this thing happened. And now I have ideas about how I can make it different. So I like that you love the chain. Many people do not love the chain.
What are the most common obstacles that prevent clients from seeing the full benefits of DBT?
I think that some of the obstacles are that people often want to change the dose of treatment. And so don't get me wrong. I think that people can benefit from even a short and simple interaction with therapy. This is typically not the presentation of someone who's seeking DBT. DBT is a pretty involved treatment. If it were meant to work once a week, only when I come into session, that kind of thing, it would probably be a different population that it was for. People come to me for treatment, even therapists I've worked with want to make a case for coming in fewer times a week, not doing the skills group, not doing the homework. And I explain it that therapy is just like any other treatment. So any medication, cancer treatments, if you were to only take half the dose you were prescribed, which in this treatment is kind of like not going to the skills group or missing multiple sessions in a row, you would not expect the same outcomes as someone who took all of the medication they were prescribed and followed the treatment plan that they worked to create with their treatment provider. So I think when people want to make changes, that's why I think I was saying earlier, is when people want to make changes, it's important to make that in a discussion with your treatment provider. The same way if you were prescribed a medication as part of your treatment plan and you wanted to stop, you should really talk to your doctor about, here's what I'm experiencing, here's what I'd like to stop, are there other options, so that you can actually still figure out what you would need to get you to your goal. I think also to get the full benefit of treatment, like we talked about, it takes willingness to participate and throw yourself in, and not only devoting time during the session, but outside of the session. I think that that's one thing that sometimes gets in the way, is that people come in, they do therapy during the session, and then when they leave the session, it just totally leaves their mind. So, which is normal, but that's part of what needs to be figured out with the client and the therapist, is how can we get that conversation that we had or those skills that I learned to show up outside of the therapy session. I think those are some things that can really help. And those, when somebody says, you need to be fully engaged in treatment, I think that's what they mean, is actually be doing the dose prescribed, thinking about it, even when you're outside of the session, being vulnerable and describing your situation and your experience as thoroughly as you can to therapists, being willing to hear hard truths from the therapist and to be active and correct your therapist if you don't think that it's not a hard truth, it's just not true. Being willing to have that conversation, because I think that that's how you're going to get the most benefit out of the treatment.
So, can you share any poignant examples where DBT had a major impact in someone's life?
Doing this treatment, I actually see so many examples of DBT having an impact on someone's life. This therapy was created for people who were contemplating ending their lives or doing behaviors that might end their lives. And every time I see a client who stops making suicide attempts or stops engaging in self-harm, I think of that as a poignant impact on their life because they are alive, and just that simple fact means that their life has so much more hope and so much more promise than it did before. In terms of a specific example, I do have permission to share an example of that impact. So a client came to me with serious problems related to PTSD. And when we started working together in individual therapy, he told me that he was not going to be talking to me or anyone else about the trauma that resulted in his PTSD. He refused to talk about the subject. And he was describing a stance that he had maintained for 3 years before we even met. This was his way of handling it. And within 7 or 8 months of beginning our work with the DBT Prolonged Exposure Protocol, and that was developed by Dr. Melanie Harned, this client was actually able to give a speech to a room of 400 therapy professionals in which he described that very same trauma that he had additionally sworn up and down to me that he would never talk about. And I, of course, was weeping through the speech because I was so proud of him. But to me, that was just that really moved me. It was a testament to the impact that getting treatment can have on someone's life. That was something that he did not have a desire to do, might not have thought he was capable of. And this is someone who actually was at very high risk of dying by suicide, had multiple suicide attempts, and went from being in that place and so isolated and unwilling to talk about or treat his trauma to actually being able to share a success story that was inspiring a room full of therapists. I thought that was really moving.
That is very moving. So, is there anyone DBT is not appropriate for?
I think so. DBT is a pretty intensive treatment. I think people for whom there are shorter and more straightforward treatments that have evidence that they are effective, it would make sense for them to choose those as a first course of intervention over DBT. So, for instance, we have really strong evidence for treatments of depression, specific phobia, panic attacks, obsessive compulsive disorder. These types of behavior presentations, problem presentations, have treatments. And so really trying those treatments first and then seeing if that treatment is unsuccessful, and if it's unsuccessful because maybe of emotion dysregulation or problems associated with that getting in the way, that might be a time to consider if DBT would be the right choice for them.
Vibh, what are you most excited about in mental health treatment today?
I am most excited to see the reduction in stigma around mental health treatment. I am seeing a lot more public discussions and conversations across the spectrum from just people who I might see on a day-to-day basis, also more celebrities talking about mental health treatment, more conversations about it in government, and that is something really exciting to me because I think that the more we can have the conversation and reduce the stigma, the more likely people will be to seek and get the treatment that can reduce their suffering. And reducing stigma and conversations about mental health also help us shift our culture toward focusing on how to help people get treatment and access to treatments. I'm really excited to see those conversations getting some momentum. People are seeking help for things that they thought they just had to suffer through before, like depression or anxiety that comes after losing a job or a death in the family. It's also great to see that where people have tried relying on friends, family, and their faith communities for support, they're now comfortable including therapy among their list of options.
If you had a magic wand and could improve one thing about mental health treatment today, what would it be?
If I had a magic wand, I would want to improve access to treatment. I think there are a lot of people in need of treatment who see the benefits that treatment can have, who are not necessarily encumbered by stigma of mental health treatment. And yet, even those people have difficulty getting access to treatment. Hurdles like financial resources or limited availability of trained providers in their area. And sometimes, even when mental health care providers want to seek more training to improve their skills, it can be hard for them to find access to the training. So since I do not currently have a magic wand, this is why I'm passionate about the work that I do training therapists, because it's something that I can do to help increase the access to quality mental health care. If we can train more therapists and have more therapists available, then at least the people who are trying to seek treatment will have one less barrier to their access.
And I like how you're doing online training, and I think that can improve access as well.
Yeah, definitely. That was one of our goals in developing online training, was to try to improve access not only for clinicians who are in the US, but for in other parts of the world who are interested in learning more about DBT and for whom it might be really hard to access an in-person training. And so we have just a combination of in-person trainings and online trainings to try to help therapists get more of what they need to be able to deliver effective treatment.
So how can my audience learn more about your work, either online or in print?
Well, I think the people who are interested in learning more about DBT and maybe the work that I do with training can look on the Behavioral Tech website. So that's behavioraltech.org. And that's the company that was founded by Dr. Linehan. And so there's information there, both for people who are interested in learning about the treatment in general, and also people who are therapists or other mental health providers who are interested in learning how to provide this treatment for their clients.
So Dr. Forsythe Cox, on behalf of myself, my listeners, and all of the people you have helped through your work, I want to thank you for your contributions to mental health treatment and for taking the time out of your busy schedule to help me and my audience better understand the field of dialectical behavior therapy.
Thank you for having me. I appreciate the work that you're doing to help people learn more about mental health treatment. I think it's another great step in the direction of reducing stigma and reducing barriers to treatment and increasing access.
Thank you so much. Be sure to check out my website, therapyshow.com, which has many resources about mental health, including a page dedicated to dialectical behavioral therapy. There you will also find how to submit questions, stories, or insights that you have about the mental health system, or suggestions about who else I can interview and how I can improve the show. I'd like to close by reminding our listeners to please subscribe, share, and review this podcast so you, someone you love, and people around the world can gain more benefit from therapy. There is no need to suffer in silence. Get the help that you need to create the life that you want.